So just want to make sure that we are done in time and that we have enough time for questions for Victor and Marcus. We'll just move on to the final presentation, which is titled Health Promotion, Case Management, and Understanding the Constructed Uses of Technology for HIV Prevention. And we have Victor Huynh and Marcus Sanzi here to present. I'm told you guys don't have a PowerPoint. No. Okay, great. So Victor Huynh completed a Master of Social Work degree at Ryerson University and started working in HIV care at Casey House, the HIV AIDS Palliative Care Hospital in Toronto. He recently moved back to Vancouver to join a HIV prevention team as a health promotion case manager, working with other men who have sex with men at AIDS Vancouver. Marcus Sanzi graduated from his BA in psychology and specialization in psychosomatic medicine at the Faculty of Health Sciences of the University of Sao Paulo in Brazil, where he worked at the Hospital of the Faculty of Medicine of University of Sao Paulo, specifically with LGBTQ HIV prevention. He also joined the HIV prevention team this year as the health promotion case manager, working with gay and bisexual men at AIDS Vancouver.
So we don't have a PowerPoint, so we're just going to sit here and talk at you. Hopefully you don't fall asleep, then please pay attention.
Sorry about that.
Marcus is just going to start off with introducing the health promotion case management program. Then I'll share kind of a case that I've been working on for the last few weeks, and then I'll just conclude with where this program is going to go for the future.
Okay, so I'm just going to give you how our program came about. So according to the Provincial Health Officer's annual report, new diagnoses of HIV are averaging 7.5% among Caucasians, followed by 10.6% amongst Asian and 7% amongst Latino, and finally 4.6% amongst Aboriginal. Remarkably, analysis by birth cohort indicates that new diagnoses have been decreasing among gay and bisexual men born before 1980s, particularly those that were born between 1960 and 1979. And contrary-wise, increasingly among those born between 1980s and 1999. So studying variables that impact the HIV epidemic among gay and bisexual men, some of the following drivers were highlighted. Stigma, HIV prevalence, sexual behavior and sexual network, HIV testing and awareness of HIV status, treatment and HIV viral load, acute HIV infection, sexually transmitted infections, appropriate health care, marginalization, mental health and HIV risk, migration and immigration, experience of racism, and systematic challenges to HIV prevention. So these drivers are complex. They overlap, intersect, and are not experienced by all individuals at the same time, at the same way. So therefore, our health promotion program takes a relevant place in prevention, since we use an intensive case management approach to work closely with our clients in order to decrease vulnerability and risk for acquiring HIV, while we are increasing their resiliency and self-efficacy. There are currently 7 case managers working within 6 different communities whose demographic are higher risk of acquiring HIV. So we do have 2 case managers working at DAMS with vulnerable women. We have Victor and myself at AIDS Vancouver working with gay men, bisexual men, and other men who have sex with men. 1 case manager at Native Court Workers and Counselors of BC, working with Aboriginal people. 1 case manager at SOS, working with immigrants and refugees. And 1 case manager at UCO, working with young people. So gay, bisexual men and OMSM face challenges in assessing appropriate and culturally sensitive health care, which is fundamental determinant of health. In 2011, 14% of gay and bisexual men reported leaving their healthcare providers because of negative attitudes towards them. So the health promotion case management program uses a more holistic approach to men's health, which can situate HIV prevention within a broader, more inclusive health framework. The program promotes sexual health that goes beyond HIV, STIs, and sexual behavior to incorporate physical, social, and mental health. Marginalization and mental health can lead to risk-taking behaviors and put all individuals more at risk of HIV infection. So protective factors such as family acceptance, school connectedness, and social support can help buffer the impacts of stigma and homophobia, improve mental health, and reduces HIV infections. The HPCM scope of practice is based on working from a client-centered approach, developing strategies to deal with clients' competing needs. The reality being that many of other services providers still do not accommodate people's unique needs. Designed under a harm reduction and strength-based approach, the HPCM program uses the concept of population-specific lens to understand the needs of each client within their priorities, honoring clients' strength and resiliency. Case managers are trained to respect and facilitate self-determination by acting as a resource for clients and encourage them to decide which needs they want to address, as well as how they want to address them. The HPCM program addresses structural and institutional barriers that can impact individuals' vulnerability to HIV, such as poverty, shame, fear, physical barriers, power imbalances, lack of a diversity of cultural approaches, services not providing environment that are inclusive of all genders and sexual diversity, system navigations in common system, immigration issues, and counseling, etc. The program also supports the development of self-efficacy and personal skills that can increase individual resiliency, assisting them to make changes in their behaviors, lifestyle, relationships, addictions, mental health, and etc. An episode of care is designed as a transitional service to stabilize clients and link them to sources of community support. Depending on the need and the complexity of each case, we provide support between 1 and 5 months. Looking at the 12 dimensions of need services, clients are assessed using an acuity scale, which is an objective tool used to establish the frequency and intensity of engagement of a client that a client requires when receiving case manager services. Also, it reflects the needs across a broader spectrum of functional areas that include medical, behavior, and environmental factors. All clients work with the case manager to develop a resiliency plan based on both an assessment and the acuity scale. If personal development goals are identified, the case manager works with the clients to develop a plan to achieve these goals and to assess their progress. While developing the personal resiliency care plan, case managers concentrate on specific and measurable goals. They are achievable, realistic to the clients with a shorter time frame that will ensure that objectives are actively followed up. When clients are stabilized, case managers connect them to the appropriate community resources and support services. All case managers follow up with their clients within a period of 3 to 6 months post-transition. So service providers can make a referral to the program using a referral form or by contacting us directly. We are connected to the STOP team, frontline workers at various communities organizations, bathhouses, IDC, VAMP, Three Bridges, Spectrum, HIM health centers, nurse practitioner, etc. Also, a referral hotline is available from Monday to Friday. between 8:30 a.m. and to 5 p.m. It is important to emphasize that the referral hotline has a real staff who can assist you through the whole process, so you're not going to call and talk to a telemarketing machine or something like that. Alternatively, in any case that the person knows exactly who they want to talk to, or the service provider knows who they want to direct to, you can do directly by saying which person you want to contact. All case managers work 4 days per week, so there might be 3 business day turnaround on incoming referrals.
Cool. So Marcus gave us a pretty detailed outline of what the health promotion case management program is, and shared some statistics from the PHO to kind of identify the need for such a program. And so, as Marcus shared earlier, the rate of HIV contraction is actually increasing amongst the younger gay male population. And as phone apps and kind of hookup sites bring people closer together and increase the number of sexual and personal encounters, this could really impact the rate of HIV contraction across many demographics. And thus we need to be aware of the different ways that technology is being used to engage one another, and the barriers and boundaries that it alleviates, and also the risks that it introduces. So I really tried to stick with the theme of the summit this year and really try to tie in technology into my presentation. Like after listening to some of the other presentations, that element's kind of missing, but I tried really hard for mine. So the health promotion case management program, it's fairly new. It just fully launched about 6 weeks ago. And so we don't really have a website set up yet, and we don't have promotional material for clients, but we do have for service providers. But all that is in the works right now. But during that time, during the last 6 weeks, our client base has steadily increased. And I've been working with one gentleman in particular that's case really relates well to the theme of the summit, and I wanted to share his story with you guys today with his permission. So I've been working with this guy for about 5 weeks now, and for the purpose of this presentation, his name will be Dylan to keep confidentiality. And everything I'm about to share with you is from a discussion that he and I had during an appointment. So Dylan, he's in a heterosexual marriage with children, and he once engaged in the sex trade with men. And currently he's living in an SRO and he has mental health and substance use issues, and he's also going through a separation. And after connecting him with a mental health team, food and income supports, and legal aid around his separation with his wife, and also counseling with the BC male survivors of sexual abuse, he describes his life as reaching like a level of stability. But however, he continues to be quite socially isolated, and the majority of his communication is done through email or through his blog. And although that I have met with him a few times in person, most of our communication is over email. So he previously worked in Boys Town, which is now Yaletown, just south of us here. But he aged out of the sex trade in his late 30s as younger men were attracting more of the clientele. And as time progressed, he found that male street sex work was almost non-existent in Vancouver anymore, as a lot of it was moving online. And this is where many of his friends currently still work, and also where he connects with other men for sex. So he shared a few anecdotes with me to discuss the pros and cons of communicating online for sex, and what kind of social and health supports that need to be available online because of it. So he was saying that as how everything has kind of moved online, you're able to reach more people and build more connections and build more of a community with people all over the city. And so people that don't usually see each other in the streets, or people that are in different kind of social groups that don't really interact in real life, are able to connect online, and you're building more of a community. And men dealing with different levels of oppression related to their identity are able to access supports and social and physical releases, like having sex with men, like by attracting them online, and thus they're able to explore a bit of their identity. And so when Dylan, he first started engaging with men for sex, he did it in very hidden areas. So he'd write messages on like the back of bathroom stalls, and he'd leave his pager number, and he'd leave like a time and place for people to meet him. And he kind of relates this to how people are engaging online now, and understands how this kind of opens up possibilities for connecting with more people and also connecting with yourself. And he also mentioned that by moving online, you're able to negotiate for safer sex practices. You can negotiate like price or where you're going to hook up or what you're going to do, whether you're going to use condoms, if you're going to party and play, or exchange sex for substances. And also there are other online outreach options that are available right now, like particularly through Huynh and through the Hustle NetReach program, where outreach workers are approaching youth that are at risk of exploitation and also adult sex workers by providing them health promotion options through like various social networking sites, dating sites, and online classified services. So when Dylan was engaged in the sex trade, this wasn't really an option for him because he would meet someone and then they would just like fuck. And he didn't really have any way of negotiating safer sex. And he really felt like the power divide between himself and the person purchasing sex, because that guy has money and the money would give him access to food and shelter, so he would almost just do whatever the guy would want. But really there should be, the power should be more in the person selling, because he should have the ability to negotiate what is done with his body, and there should be kind of a mutual agreement. So then he started discussing the cons of going online and how you run the risk of running into like fake profiles, and you show up for a date at someone's house and they're not who you thought it was, and what do you do now? Like, how do you negotiate that? How do you still go through with it because like you really want to have sex, or you need some money for food, or you need money for whatever? But in Dylan's case, like he would kind of meet guys that were really, really attractive, really hot to him, and like I said earlier, he would just do anything that they wanted because they kind of looked like they were safe and clean cut and hot. And so he feels that there should be more options for support and advice when kind of you're on the go. So maybe like developing more online apps, or developing things you can use on your phone, or just like something to put in your back pocket, because not everyone does have access to the internet or smartphones. And there's also dangers in meeting strangers in their homes, because you're in a new and uncomfortable environment. You don't know what's around, you don't know where the exits are, you don't have anything that can really keep you safe. And there's also the possibility of having forced sex. But for Dylan, he always had sex in really public spaces where he felt like there was safety because people are always around. So he wanted to kind of develop a way where he can make private sexual acts a little more public. So after identifying some pros and cons, he also identified that there is still a risk for HIV even if you're super safe. And so he came up with some options that he thinks should be explored. So he wanted to maybe create an online community for people who use the internet for sex to track their dates. So you can kind of put online like where you're going, who you're seeing, what you're doing, so someone always knows where you are. But like this kind of exists right now for sex trade workers and youth at risk of exploitation through Huynh. But he thinks that it should be extended to other vulnerable communities like new immigrants, or different communities where men who have sex with men is still very taboo, or just like the gay male population in general. And also creating more community groups like Boys R Us that supports current and former male sex trade workers, and to really build community security and safety amongst different communities. So part of the health promotion case management program, in addition to our intensive case management work with people that are very high risk of acquiring HIV, we are a very mobile team, and we go out to the community, meet people wherever they're at, go to their houses, but we also do a lot of outreach. Like currently right now, I'm working out at Steamworks as well on Wednesday nights, connecting with people that are coming in to get tested, and also at Vancouver Native Health at the Dudes Club. And where Marcus and I are currently planning support groups for gay and bi men and also queer men of color. How they work is Marcus' group will be kind of a closed group where the goal is to build a tight-knit community where people feel really safe to share things. And there's also an option for a drop-in to encourage people to come when they can, and also to provide a bit more autonomy. And hopefully in the future for our program, iPads will be introduced, so we'll eventually have a bit of an online presence where we can offer safe sex education and different ways of negotiating sex, and health promotion options like looking at the social determinants of health that impact vulnerability to HIV, and also providing referrals for resources like housing, income, food. We either refer out to the community, or we can take people on as clients and work with them directly. And also providing social supports, like maybe just having someone to chat with, or having people engaging in sex letting us know where they're going so we can keep an eye on them. And also safety planning, resiliency planning, and crisis counseling and interventions, and hopefully we can do some of that online to reach more people. And finally, we're also developing a web-based case management application that creates a detailed picture of each case and all the specific services in which the person is participating in. So, like, for example, for Dylan, this would be really great for him because he's engaging in so many different services right now, and it'd be really great to see where he's going, what's really benefiting him, and to really be able to create workflows and reminders, referrals, and develop like strong, steady outcomes from. And so this web-based case management application, I think, will really help create a better understanding of the client's needs, create current situations, and also help create plans for the future. And so in conclusion, as more people start to engage online and as different health concerns continue to rise and the state of HIV and AIDS continues to change, service providers really need to be more aware of the options that are available for the community, and there needs to be a greater availability of services and resources for the most vulnerable of communities. And so a project like the Health Promotion Case Management Program really addresses the guiding principles and goals of the Ministry of Health's Hope to Health initiative, which is where this program kind of developed from. And these goals are to reduce the burden of advanced HIV infection on the health system, to improve the quality of HIV prevention services, to improve the reach of HIV support services for those vulnerable to HIV, to reduce the number of new HIV infections in BC, and we hope that this HIV prevention initiative can be a leading model of care for other cities and provinces in Canada and elsewhere, hopefully. And thank you.